So as Allison said, this is a hot topic. It is a hot topic across the country and actually across the globe. As you'll see, this is a very aggravating factor, I think is the best way to put it, for a lot of institutions and providers. And so we're going to try our best to give you a broad overview. One of the concerns is, and that's why there's this Surgeon General's warning, is there's not a lot of publications on this. There's not a lot of best practice. And for those of you who know me, I like to give talks based on that because of that. But really and truthfully, for this talk, you have to go out on the internet and you have to look at newspaper articles and different sources to really get an idea of what's going on. So for that, I apologize. Michelle will save me at the end because he does have some actual data that he can share with you. So let me ask you this. Would this be a public health problem if we identified something that it entails 40,000 deliveries a year in the United States, where they get late prenatal care and very minimal access to their care and records before that? They have a number of unaddressed medical problems as they arrive with both the mother and the baby. They really want a scheduled delivery. In fact, in some populations, they want it on a certain day, on a certain hour because of numerology calculations. There's very little cultural understanding between the caregivers and the patients. And as soon as they're delivered, they would like within a few days to fly back home and not be here. I think if this was a call to arms for giving insurance to somebody or things of that nature, if these were Medi-Cal recipients that somehow people had just kept out of the system, we would be all over this. And yet, if you go, as Allison said, if you go upstairs, probably every day here, we are dealing with one or two of these cases. So let's talk about the problem and the definitions. First question is this just a form of medical tourism? What is medical tourism? Well, it's pretty well known to us. This is a common thing. If you go to the Mayo Clinic, you realize that it's built in Rochester, Minnesota, out in the middle of cornfield, and they don't have thousands of patients from the surrounding counties. They certainly take care of the folks that are there, but people are literally flying all over the planet to get there. And so I would argue between there, we'll talk about in a second, the Cleveland Clinic. I would even put the Hoag Orthopedic Institute starting to do this. Once you get good enough, people will fly to quote unquote get the best care. Okay, so now, how does the Mayo deal with international patients? Well, if you go to the website and look up what are the particulars, the bottom line is they talk about if you don't have insurance, bring payment that'll be due at the time you leave. They're very upfront about the cost of their care and getting reimbursement. Now, if you're taking care of a Saudi prince, in general, this is not a big deal. Okay, they rent if you've ever been to Rochester, they rent the top floor of most of the hotels there and bring the whole family, and then they go over to the clinic and have their annual checkup and pay with the credit card and walk out. That's the typical visit. Similarly, as I said, Cleveland Clinic has marketed this and pushed forward. And they, again, have very specific, by the way, we certainly welcome, we want to take care of you. By the way, we accept traveler's checks, personal checks, money orders, cash, and most major credit cards. So that's medical tourism. That's again, selling your expertise and going forward. But here's the difference. The difference is the fetus and certainly the issues around citizenship. What we're talking about today in birth tourism differs from medical tourism in that people are not, no offense to my colleagues upstairs, flying here to be taking care of folks because we deliver babies on a world-class experience. Allison's working on that. We will get there. But I'm just telling you, that isn't their real goal. And so the question is, what does this have and where did this come from? The other thing this is not is talking about specifically anchor baby. You'll hear the term anchor baby. It's used a lot in the news, a lot in the print. And really, it's really a pejorative term for a baby born in the United States by a foreign national with the idea that, hey, they will then get all the rights and this will help me out by having the baby here. The reason they're not the same is really while most birth tourism babies are anchor babies, the greater population, if you look at the statistics for anchor babies, of the 400,000 that are estimated to deliver in the United States every year, most of those are foreign nationals that have come here for other reasons and things of that nature. And so the bottom line is the best way to think of it is birth tourism babies are a subset of that. It's interesting though, it's a love-hate relationship between anchor babies and what we're dealing with. And what I mean by that is if you look in the United States and ask the question, where are all the deliveries coming from, increase, in other words, our fertility rate, i.e. replacing the population, so 20 years from now we'll have workers and things of that nature, it's a lot from these anchor babies. So it's, again, sort of a love-hate thing. We want to be careful when we're dealing with this issue because the bottom line is this is future population. And as you know, many countries in Europe and in the UK are having trouble keeping their fertility rate up enough, and they're having to import foreign workers, and you can hurt your nationality, if you want to look at it that way, from doing that as well. How many of these are birth tourists? Well, obviously, it's not on the birth certificate. For Allison to know how many there are here, you kind of got to look on the demographic form and, believe it or not, read between the lines. The best estimate is about 40,000 babies. I think these folks, the Center for Immigration Studies, which is sort of a group all over this, spent a fair amount of time trying to get a handle on how much it is. So again, going back to the anchor babies, it's about 10% of those are birth tourism. Now, where did all the ties to birth tourism and citizenship come from? Well, it came from the 14th Amendment, which was passed, just after the Civil War, when we were really trying to get immigrants into the country and build the population up. If you think about 1868, when it was passed, that's when we were trying to colonize the western states. That's when the growth and expansion was occurring, the sort of post-war replacing all the casualties from the Civil War, et cetera. And so we became very generous. So the bottom line was everybody who was born here became a citizen, with the exception, I think this is kind of funny, with the exception of children born to foreign diplomats. So if you're the ambassador from China, guess what? Your kid doesn't get this, right? On the other hand, if you hop on a plane, fly over here, from Shanghai, you're good to go. The other thing, of course, if children are born from an invading army, this hadn't obviously happened, they don't count as well. We don't count them as citizens. And it brings up the legal term of jus soli, meaning literally the right of the soil, meaning that being born in the United States on our soil means that you're a citizen. And again, it's not, as I'll show you in a moment, not a common thing in the world. For example, the last one to get rid of it was formally Ireland, who in 2004 changed their constitution. And it turns out that only 30 of 194 countries in the world have jus soli as a thing. We're some of the lucky folks. Now, this is not to be confused with what most countries do, and that's jus sanguinis, or right of the blood. So if I'm an American citizen and I father a child and the woman's an American or the woman's an American citizen, then we can pass that right to the child to be a citizen. And most countries have this through there, and then there's actually international agreements if someone's born and they're stateless at the time. Think of some of the folks that have been kicked out of their countries, et cetera, to deal with that. Obviously, that's a whole talk in itself. The dark blue countries are the one who have unconditional jus soli. You can see it's a very minority, and they tend to be in our hemisphere. Again, these were enacted because at the time we were trying to colonize these countries. So the United States and Mexico and Canada all fell into that group where we were looking for citizens. But really, outside of Pakistan, and I'm blanking, I think y'all may know your geography better than me. Is that Uganda? Yeah. The bottom line is there just aren't many countries in the world that have that. Australia has it, but with restrictions. As I mentioned, the 27th constitutional amendment of Ireland did away with theirs. They were sort of, if you go back up and look, that was the change, and that's where they went from a dark blue to a light blue, where they give it under certain circumstances, but not to everyone. So where do all these folks come from? What are the different areas? I mean, I think if you walked upstairs, you would think they were mostly from China. I think that's the majority of ours, but there are certainly other countries. And again, China, as I'll show you with some of the news articles, has gotten some of the biggest press, but they're also up in the LA area. Some of our ministries there are dealing with influx of Koreans as well that do this in a similar fashion. Nigeria and Turks come. I talked to some folks down in San Diego, and they're actually beginning to see the influx. Their big thing is the Turks coming over that want to do it. And again, what happens, just as shown as the Nigerian, the guys that run these begin to, they advertise these and they organize it, et cetera. So it's just, where does it come from? The Russians, it's interesting, and all politics aside, although I'll bring it back in a few minutes, the sort of bottom line is Russia is one of the most frequent users of this. If you're an affluent Russian, particularly in South Florida, this has become a big thing. And Brazil as well, same thing, folks come over, etc. The Russians, how do we know the Russians are here? Other than, I don't think it's been in any of the Senate or House of Representative hearings, but one of the TV stations in Miami did sit outside of Aeroflot's check-in, and as women came by with their newborn babies, asked them if they came here to have their baby, and they were so excited to say yes. And they went on to do a story and found out these people were paying $20,000 to $100,000 for the services. Now, again, this is not to be confused with the influx of folks coming across mainly our southern borders. They're really coming here more so just to be in the United States for the work itself. They're not purposefully coming here. And whenever you get into, and the reason I bring this up is this is a really sensitive especially with all the focus on immigration right now. You have to be very careful to separate this out when you have this discussion. Although, as we talked about numerically, this is actually a bigger group. So, is that the only reason people come here? Well, not necessarily. I mean, there are reasons for it. I mean, it does. People talk about free schooling, free medical, free citizenship, getting around the two-child policy. They now, that's up from one-child policy. China finally figured out, by the way, we won't have any workers, and and there, by the way, they're there where they're beginning to have problems. So it's two-child, but still it's only two-child. In the United States and Canada, as I said, we're popular destinations, but as well, Hong Kong has the issue for people coming in it, and the mainland Chinese, because Hong Kong citizens get different privileges, want to go over there and have their children have that. Now, what are the benefits? Well, if you want to find out a real good list, then you go to www.starbabycare.com, which is a Chinese website that lists them out. So it has, you can apply for loans, receive senior supplements your baby will get. The parent, to you as the parent, when the child reaches 21, becomes an adult, you can get your green card. You get the idea. That's how they're obviously marketing this as the benefits of citizenship. And they're pretty slick websites. When you go on them and you look at them, these are not, you can tell they've spent a good deal of money on this. This one, if you pop it up, you get this, friendly American telling you the benefits of birth tourisms and what's the risk and benefits of doing so. They also give you helpful hints. First of all, you got to watch out, because if your belly's too big, they may not let you in. So you want to try to sneak in when your belly's not sticking out. The other thing is, don't fly into LAX, because they're really checking at LAX, or I assume John Wayne. So they recommend that you fly into Las Vegas or Hawaii and then take a domestic flight in. So you check into the United States in a more tourist-friendly setting. And again, if you look at this and see what's going on, the influx has also led to increases in the number of particularly Chinese students in different schools. And if you break it down in U.S. high schools where these Chinese students are going, it's not so much in the public sector. That's the little pink. I know the colors are a bit skewed, but the little slice, it's really into evangelical Christian, Catholic, and private sector schools. So if you want to see where these kids are going to end up, and they frequently will bring them back into the United States for high school, so they have a better chance of getting in a more prestigious university. Again, we're not the only destination. This is the Brits, the National Health Service has figured out, here's how much it cost us to take care of these. Hong Kong and those guys have checked into it. The Canadians have checked into it, etc. And there's been lots of, like, say, if you look at analysis across the globe, this is analysis of the Hong Kong and what that means to their economy and things of that nature. A little bit more non-medical data. Medicaid thinks that they spent about $2.2 billion in 2014 on paying for these pregnancies where they just didn't get, the hospital or the doctor didn't get reimbursed. And so they converted them to Medi-Cal, and Michelle will have better numbers, is what I would say. And again, this is something we live in a state, California has closed 84 hospitals with unpaid bills. So it really aggravates an underlying situation. Aside from that, there's a lot of bad press. You've seen, if you've watched the TV, it's been on the nightly news. It's been on different venues. It's been on cable. This is a CNN report where they looked into it in great detail and talked about it. It's been in NPR. This particular one had to do with the arrangement that a New Jersey hospital had actually helped and gone out and promoted this in an effort to get more paying patients and things of that nature. It's obviously been in for those of you who get the register, you may have seen these articles. This particular one, this happens to be a place in Irvine that they busted into, and the storyline went that the Irvine company's renting these and making a lot of money. Tourism in the packages in Orange County. This comes out of that report. Talked about how the more you paid, the more perks you got, including trips to Disneyland, shopping malls, and the firing range. And do they ever skip the bill? Well, this is one sort of famous patient who, first of all, they move in, they transfer, wire transfer $203,000 into U.S. accounts. They got the necessary medical care at the Wynn in Las Vegas, the Bose store, the Rolex store in Costa Mesa, and Louis Vuitton in Beverly Hills. And then they went to the hospital. They had a $28,000 bill that the father paid $4,000 and then transferred out $220,000 out, wired it back to China and left, and that was paid in full. Again, we talked about this with the hotel, and this story unfortunately ended up pulling in Hoag. And sort of got us into it. I think the problem, and putting on my provider hat as a provider and as giving hospital, I mean, we can't turn people away. We're not going out of our way here to get these folks to come, obviously. But the question is, would we say, no, you can't bring them here? And again, the answer is you can't do that as well. So unfortunately, when the register read it, they put it in as, oh, well, they even have special cash packages, which are really set up for our, actually it's usually affluent patients who just don't have insurance, so that they don't have Anthem to negotiate for them and pay that. But anyway, bottom line is they spun it as we were recruiting them. This is the data, by the way, that Allison was referring to. This comes out of our California Maternal Data Center, and you can see the green is the Selfpay group, and you can see over the past few years that green part got pretty big, and a lot of the growth in our delivery volume here at Hoag is secondary to those particular deliveries, and again, not a great statistic to have. Well, there has been pushback and things of that nature. The Canadians are really rethinking their 14th Amendment, and they are seriously thinking about getting rid of it. You're seeing some really negative articles come out on these maternity hotels with people identifying them and marking them and going after them. There are prosecutions. This fella ended up getting taken to court for bringing these in and setting up sham marriages. And so the feds went after him. This was out of the Washington Post. They are raiding some of these hotels because a number of people are not declaring legally when they come in, and so they're using that as a way to shut some of these down. The problem is that really the fines many times are less than what's being charged for these. And so the way the folks look at it is the bottom line is for them to have another kid in China, that fine would be greater than the cost or anything that they would incur over here. So it's not really that fair. Can they get insurance? Yes. In fact, this is off of one of their websites that has this, and it does give you a link to this company that will sell limited insurance for when you're traveling in this country and things of that nature. So they could get insurance to cover their bills as well, but as Michelle will tell you, they usually don't. There are some dangers. This was a $5 million lawsuit against a hospital and a doctor up in northern Orange County where there were complications. The patient bled, had bad things happen, and the bottom line is they came back and sued the hospital and the doctor even though they weren't citizens. And the bottom line is it's not working. None of these pushbacks are doing much. So the question is will our great president make it? Well, the sort of good news is that he does have obviously an anti-immigration view of life, and this is even the most avid immigration folks have a problem with this. The problem is, particularly in the Russian things, all this has done is better advertising. So this got put out. Russians flock to the Trump properties to give birth to U.S. citizens. And I guess the babies get a free Make America Great Again cap if you do that. So with that, I'm going to turn this over. There's a couple of, I won't even call it data, this out of reproductive biomedicine, talking about the cost of coming across the border and having and how that works out. And the bottom line is obviously the cost, especially with multiple pregnancies and complications, does not get paid back. This article looked at, hey, what are the legal repercussions? And the bottom line is our hands are pretty much tied. We don't have anything. We can't turn people away and not give care and stuff. So fortunately, to get some data, our colleagues at Chalk put together their experiences on the babies with the NICU. And so we're going to have Michelle come up and present that.
All right, thank you, everybody. Very honored to be here today. So basically, we had some anecdotal observation in the NICU at Chalk a few years ago, and this observation was birth tourism is on the rise in the area. We could have seen more and more families that they have told us they're here in the U.S. primarily to obtain the rights of citizenship for their children and were planning to go back to their home country. Then for one reason or another, their child and being in the NICU unexpectedly mostly. Some of the themes that was common among many of these families, there was particular parental anxiety, and the anxiety was related to several issues. Some were related to how to navigate the system. Another issue was financial liability, especially for those who weren't expecting to be in the NICU. Now they go from some sort of a preset financial arrangement with their birthing center and OB provider to come into the NICU, which, as you know, very costly. And we learned that many countries, the family dictate care based on their ability to pay. So through translation whatsoever, several families would said, back home, you will tell me the baby need antibiotic, I'll ask how much, you'll tell me the price, and if I don't like it or I don't want to pay it, you wouldn't give the antibiotic. And we had to explain that it doesn't work this way here. And also almost always there's travel arrangements. So as they book in their flight in, they already have a return ticket expecting to be a few weeks or a few days after delivery. And if you haven't visited the NICU before, the NICU doesn't work this way. We don't know what's going to happen tomorrow. We're just going one day by one day and setting milestones for the family to when we go home. But we cannot tell anybody with certainty you're going home in that day. You can make a travel arrangement unless we're really close to discharge. And also there was some social challenges or cultural challenges. Even with using professional interpretation, even that many of the providers, doctors, and nurses speak the mother tongue for some of the families, there will be some communication barriers. And those barriers could be just as simple as misunderstanding each other, or as simple as you feel like the interpretation is not doing a good service, or not. There's a culture component to the communication rather than just translating word to word. We came across situations where the child care became so complicated that the family realized this child will have complex medical needs that will continue for the rest of his life, or at least most of his early childhood, and they have decided it's for the child's best interest to be staying here in the U.S. and being adopted by family who resides here. So we have seen several of these cases, and every time the family will be very sad and very disappointed that they have to leave their child behind, but they don't the child's best interest because they cannot continue medical care, or they don't think where they live there will be availability to continue the medical care that the child needs. Another social or cultural challenge that we came across is there was one particular case where mom was taking some herbal supplements while she's pregnant because herbs are great, and this herbal supplement was supposed to be antioxidant, but, so it's good for your body and everything. But this particular antioxidant acts in a mechanism that blocks a blood vessel that's essential for the fetus life. It's called ductus arteriosus, if you remember from your previous studies or your experience. So the baby will be delivered with a closed ductus arteriosus, and when it's delivered with such a thing, they have something called significant pulmonary hypertension that require definitely intensive care, and they could be close to dying from that if they're not provided with the care they need. So all these anecdotal observations that we had in 2012, 2013, and 14 made us wondering and going down to the literature and trying to see how we can tie these pieces together, how we can better serve these families and better serve the children. And there wasn't much out there. As Dr. Lagrew has very nicely shown us what's in the internet, there wasn't anything to understand, and weren't anything that we can put fingers on right away. We learned a lot about the birth tourism and the 14th Amendment of the Constitution, about the issues that's ongoing, as we heard from Dr. Lagrew, but there wasn't much out there. So comes to the NICU, and the NICU is such a specific and unique branch of medicine that has its own issues. And these issues, NICU admission is not that rare as we would like to think. NICU admission is not only for preterm babies. So you will see from this epidemiological study that among normal birth weight infants, about 4% get admitted to the NICU. They usually get admitted for either transitional issues or congenital anomalies or issues related to surgical or medical issues. But for the very low birth weight babies, meaning babies less than 1,500 grams, about 100% get admitted to the NICU. And this data is a little bit old. Currently, most of the hospitals they have a policy, if the child is less than 2 kilos, he'll get admitted to the NICU. So when you lump these numbers together, according to the study, the NICU admission rate is close to 8% of all live births. Marsh of Dimes has more information in that, looking at more recent numbers, epidemiological numbers, and they come up with the conclusion that about close to 15% of all live births will come to the NICU for some time. And they broke it down by gestational age, as you can see here in the graph. And as you can see, it's more common, obviously, in the preterm infant and less common in the full-term babies. They also broke down the length of stay and the cost of care for these NICU admission by gestational age as well. And as you can imagine, the smaller the baby or the younger the child is born is more costly and longer length of stay. So for example, a baby who's less than 32 weeks, on average will stay for about 6 weeks in the NICU and will cost $280,000. And this is in 2011 dollar amount. So you can try to imagine how it costs now and how it costs for a 24-weeker or a 26-weeker versus 32-weeker. But on average, for all babies admitted to the NICU, length of stay is about 13 days, with 2011 dollars of close to $75,000. So besides NICU being a unique branch of medicine, nobody planned to be admitted to the NICU except if they really have a prenatal diagnosis of some sort of congenital anomaly whatsoever, and everybody's trying to avoid it. The NICU parent also serve as a unique population because they're actually, beside taking care of the child, beside providing care for the child, but you feel also you're the family's doctor, you're the parent's doctor. And NICU parents' stress and anxiety they go through is very similar to somebody who has been to war, literally. They go some sort of a post-traumatic stress disorder that has been very well studied. A lot of people look at their stress and depression level that they get exposed to, and it's not only affects their financial, as you could see from the previous slides, and if they have insurance or not, but also affect relationships. And unfortunately, we have experienced that with in the NICU sometimes when families will break up or divorce, and they have stressors in their life, and having a child in the NICU was a kind of an added stressor or what pushes them off the cliff sort of thing. So it's pretty tough on everybody, and you can imagine doing all of that for somebody who's supposed to be here in the country for a short visit, who doesn't speak the language, who has communication barriers, and has travel plans and all of that, and maybe has families and other responsibilities for across the ocean that they need to go back to. So to summarize for you the facts that we had so far, as we learned, the U.S. grant unrestricted birthright of citizenship. About 10% of all newborn require admission to the NICU. NICU admission is not easy, socially, financially, and the parents and everybody. And there is a lot of media reports, but there is no peer-reviewed publications. So we took the task on ourselves to study that. And basically, we came up with a retrospective study when we reviewed the medical records for all the children admitted to the NICU between 2012 to 2015, only as a CHOC NICU. And every NICU patient, when they come to the NICU, they usually get screened by our social workers, colleagues, and case management colleagues. They get interviewed, some sort to offer them any resources for help, to make sure they enroll themselves in any programs they need to be enrolled in, and kind of to make sure the home environment is safe for the child to be going home to. So we looked at the documentation of our social work and case management teams, and we only identified birth tourist babies for those families who identify themselves to our social worker and case management. So we didn't go based on our own assumption or based on our knowledge or not, but we went by the families who, in their social case management interview, they have told to our team that they are here only as birth tourists. And we analyzed all this record, as you will see in a second. So some result, in a 3-year time period, we had about 2,000 admission total to the NICU. Only 2% of these were children of birth tourism. The total number was 46 neonates. They were admitted about 50 times because there is 2 childs were readmitted once and 1 was admitted twice. So that make it a total of 50 admissions. When we divided the timeline of the studies of 3 years over 3 epochs of 12 months each, there was 7 admissions in the first epoch. There was about double, 12 admissions in the second, and there was 31 admissions in the third epoch. So as you can see, the trend was increasing in the study period. We finally analyzed the birth tourism group to describe them by comparing them excuse me, comparing them to a random sample, 2-to-1 ratio of non-birth tourism families or children, So these were babies who were admitted at the same time, randomly selected, admitted same months, just 2-to-1 ratio. So as you can see, 46 to 100. And in red, what was statistically significant in comparison among the group. So the first thing was maternal age. As you can see, the birth tourism group were older by a few years in comparison to the non-birth tourism group, and that was statistically significant. And this is something we kind of guessed. Most of the families who would come here, they're usually affluent, older, they plan for it and they stage for it, versus, you know, our 18 years old or early teens who are having babies here locally in the US. They're mostly C-section. This is something also we anecdotally observed, and Dr. Lagrew touched a bit on it. As there's a lot of elective C-sections among the C-sections for cultural reasons or for reasons that the family believe it brings good luck for the child and the family. So as you can see, 70% C-section versus 48% in non-birth tourism group. And in the elective cesarean section, among those, among those 33 women, there was 23 women who were totally elective, non-medically indicated, so that make it 70% versus 35% was elective C-sections. The rest were medically indicated. And what we call inborn is the children who were delivered at St. Joseph across the street from us. There was only 15% inborn delivered at St. Joseph. The rest were delivered everywhere else in the community, including Hoag. And for the non-birth tourism group, CHOC, as you know, get referral from all over the county and nearby counties. So 50% were from St. Joseph, 50% from everywhere else. There was no difference among the children in terms of other factors that determine morbidities and mortalities in neonate, such as gestational age. They were similar, birth weights they were similar, gender, what happened to them in the delivery room in terms of Upgar scores, and what kind of care they needed in the delivery room. When we broke down the two groups by ethnicity, here's the non-birth tourism group. It's kind of a good representation of the populations that we see every day at CHOC. Between Hispanic, white, and everything else in between, representing Orange County as a true melting pot. The birth tourism group were mostly Asian, and few were white or actually Middle Eastern, but mostly from mainland China, Hong Kong, Taiwan, and the Gulf areas in the Middle East. So we also looked at the reason for admission and why these children came to the NICU to begin with, or were referred to the NICU. And here in this pie chart, you will see for the control group, again, a good representation of what we see usually in the NICU. About 25% were preterm, and this was the sole reason for the admission. And 34% was other reasons, which could be something as simple as jaundice or rule-out sepsis or what the likes. And the other percentage, the 40%, divided between cardiac reason, respiratory reason, neurological, and surgical reasons. They came primarily for surgery. And 20% of this group needed surgery. For the birth tourism group, the referral reason was mostly needing surgery. So 44% of those children, they referred to CHOC from the community because they needed surgical operation. And the rest was other reasons as well. But you'll see very less preterm in comparison to the control group. And among these 46 babies, 50% needed surgery in their admission. Another hospital outcomes that we looked at is mortality and ER visits and what's the like. So for in-hospital mortality, there was close to 9% that died in the hospital, versus only 1% in the control group. And because the number is small and the events are rare, you cannot plot that statistically, but you can see the numbers here. For ER visits within 30 days, the families that came back to the ER within 30 days, at least CHOC ER, don't have access to the other emergency room in the area. There's about 15% of the birth tourism babies that came back to the ER, double to the control group, which is 8%, and that reflect also on the admission or readmission within 30 days to CHOC. And this is not only the NICU, but also the floors. So 15% of the babies get readmitted within 30 days versus only 5% of the control group, and that approach statistical significant. And I think these 2 points reflect on the control group. Usually when they go home from here, they have the resources, they have way of communications, they have their primary care provider that they trust, and they call their primary care provider, maybe they go to urgent care or not, and they have enough resources versus birth stories and baby who get discharged from the NICU. The family feels maybe a higher level of anxiety, a higher level of stress that they come and they don't have a relationship with a primary care provider, so they feel more obligated or more urged to come back to the hospital right away. I mentioned to you early in the anecdotal slide about the adoption, and among this comparison for the birth stories and babies, was about 10% get adopted for reasons that was unplanned. The family came across a situation where the children needed ongoing medical care, and they have decided to place the child with a family that lives here, versus a control group. There was only 1% adopted, and this was a case of a family that, or a mom that was having a drug abuse problem, so the child was placed with a foster family. Looking at the health economic of the issue, comparing both groups again, from a health insurance standpoint, the birth tourisms almost always were self-pay to begin with, but by the time of discharge, maybe one baby or one family obtained some sort of private coverage, and about 1/3 obtained CCS and Medi-Cal, the California Children's Services, and 2/3 remained in self-pay. That's kind of a rare event to be a self-pay in the NICU and among the locals here in the U.S. Because the children conditions always qualify under CCS and under Medi-Cal if the family cannot afford. So the control group will represent our NICU population almost 50-50 public versus private insurance. For the length of stay, the birth tourism group stayed longer in the hospital. As you can see here, this is a median with interquartile ranges, almost double to the control group. And their hospital charges were higher, so and these numbers are hundreds of thousands of dollars. So this is $7,000 versus $103,000, and that was also statistically significant. And when we divided the number to be charges per day, that not only directly related to length of stay, but also more of how much it costs per day to reflect in the complexity of care, that remains significant. And I think both these reasons are directly, or both these issues are directly related to the reasons for admission. If you remember the reason from admission slide, there were more babies coming to surgery versus the control group. So the study was published in the American Journal of Perinatology in 2016, and I think you have a copy in the handout, and Dr. Lagrew referred to that. But before it was published, an abstract form was accepted in the American Academy of Pediatrics National Conference in 2015, and the American Academy of Pediatrics found it interesting enough, so they decided to include it in their press release. And since they did this, a lot of reporters picked on it and have either cited the study or have called me for a phone interview. But as you can see here in the slide, Science Daily, mid-page, Infectious Disease in Children, Eureka Alert, Voice of America, and even here Orange County. And it also made it to the international press. None of this was planned, but somebody found it and translated word to word in the international press. And if you remember, end of 2015, 2016, that was among the presidential heated political debates and stuff. So people were tweeting this right and left at Ben Carson, Ted Cruz, Donald Trump. I was really nervous around this time and had to set up some internet alert to know what's going on. And finally, Homeland Security picked on it. They called me earlier this year asking if I have any more information. So I said there's no more information except what's in the publication. The take-home points is there's a lot of limitation to the study. It's a single center, it's descriptive, it's self-identified. So it could be more numbers, yes, could be, but we don't know. But we know for sure that birth tourism increasing in the region, if you remember from the epic slide, as the numbers increasing every epic. And the difference in outcomes probably is not related to where the family origins from. Probably it's related to the reason for referral and related to maternal factors such as advanced maternal age and the preference for C-section and whatsoever. However, NICU admission rate among this population could be higher than the 10% that we have seen in the previous study because, again, as we said, the advanced maternal age, maybe the maternal stress from the long travel, and potentially it could be that the family knew that the child has something in the prenatal ultrasound and they decided to come in an airplane and come to the US for treatment for their children. That's a possibility as well, but we don't know that for sure. We don't have this information. But in summary, it's associated with unanticipated medical, social, and financial challenges, and we definitely need larger studies to better define the impact on families, children, and the healthcare system for sure. So a study should be kind of multi-center perspective, where everybody gets screened, not only those children that make it to the NICU, but looking at cesarean rate delivery, looking at NICU admission rate, looking at prenatal care and any prenatal morbidities for the baby and mom diedads, and also health economic, and maybe even, if possible, psychosocial evaluation. I would like to thank you all for your attention and thank my colleagues who are the co-authors of the study and the Chuck NICU group who helped me get this done, UCI Statistics for the support, and the NICU social and financial services.